Good morning, everyone, and welcome once again to the next IC. So, can I have this slide, please? Yeah. So, instruction course number 117 we are doing now, and this is basically all about how we resurrect our trabeculectomies. Trabeculectomy still remains the most commonly performed procedure for glaucoma, and we all know and we all face failures. Even though the procedure is good, but still, in fact, all glaucoma procedures, they have a high rate of failure. So we don't have a perfect procedure yet. So in this in IC, we will talk about what we can do once the surgery has failed. There are different options available, but I think if you can revive your surgeries, that would be the perfect solution for us. So in this, what we will be talking about is a little bit the pathophysiology of trabeculectomy failure, how and why it fails. Then there are different ways of what we can, restart functioning. We could do an Bleph needling. We could do, Aventurno revision. I will also be introducing to a limited posterior Bleph revision to restore trabeculectomy function. And then we have a fresh trabeculectomy, or you can do the, trabeculectomy the same side, the revision trabeculectomy. And then also something about how do we handle post procedure, how do we handle these cases. I'll take you the first talk that's by Dr. Natasha Gautam. She's not here. She actually recently moved to US, but she has sent a presentation, recorded presentation. So I'll play that on her behalf. You will have to open from there, please. Yeah. That second one, number 2. Yeah. Video भी है इसमें, चलेगा. Go to the next slide. Video चला. Here run this video. Yeah, okay. Sound नहीं आ रहा. हाँ, या साउंड है. वीडियो अलग से पड़ा होगा, अलग से भी होगा इसमें.
अच्छा, मैसेज इसमें
इंक्लूडेड भी है.
अच्छा.
दिस वन. या ओके.
My name is Natasha Gautam, and I'm going to discuss the pathophysiology of trabeculectomy Bleph failure. What is the ideal outcome of a glaucoma filtration surgery? To have a diffuse filtration Bleph. But what is the real scenario? There is a 10 to 60% chances of trabeculectomy failure, and it depends on the case selection. And what are the reasons for failure? The most common reasons are the subconjunctival fibrosis, which lead to scarred, encysted or flat Bleph. There could be a blocked fistula due to iris, blood clot or vitreous. And there could be Bleph leak or excessive filtration, which again leads to the Bleph failure. Coming on to the most common cause, the subconjunctival fibrosis, which is the most common cause of failure, and it happens due to fibroblast proliferation and scar tissue formation at episcleral tenon interface. The long-term success of trabeculectomy Bleph depends on the individual wound healing response. Regarding the phases of wound healing, it passes through the cascade of coagulated phase, then comes the inflammatory phase, proliferative phase, scar formation and wound modulation. In the coagulative phase, the activated platelets from the bleeding vessels release the growth factors like the platelet activating factor, serotonin, platelet-derived growth factors, VEGF, and various cytokines like interleukins and TGF-beta, which act as chemoattractants. Then comes the inflammatory phase, which causes the influx of neutrophils as early as 24 hours. There occurs differentiation of monocytes to tissue macrophages, which happen around day 3, which release TGF-beta, PDGF, FGF, the epidermal growth factor, and simultaneously there is activation of T lymphocytes, which release interleukins, PDGF, and other cytokines, leading to continuous inflammatory phase. Then comes the proliferative phase, which happens around 1 week, in which there is generation of new tissue matrix through angiogenesis and fibroplasia. The platelet-derived growth factor and the TGF-beta are the main pro-fibrogenic cytokines, while the fibroblastic growth factor and the vascular endothelial growth factor are the main pro-angiogenic factors. Scar formation occurs around 2 weeks, that is around day 14. The fibrovascular granulation tissue starts, leading to development of procollagen, tropocollagen, ultimately collagen formation occurs. Simultaneously, there is wound modulation, the remodeling phase, which begins around 3rd to 4th week, in which fibroblast cell death occurs by apoptosis and remodeling of the primitive fibrovascular tissue occurs into a mature scar. This phase is primarily mediated by the matrix metalloproteinases and plasminogen activators. Let's see how is the wound healing after glaucoma surgery. It is much longer and leads to much more scarring than normal conjunctival wound healing. The proliferative phase of wound healing lasts much longer after GFS, and it happens because of excessive proliferation of tenon and conjunctival fibroblast, their differentiation of the fibroblast into the myofibroblast, and the uncontrolled production of the extracellular matrix. This is a nice study to show the role of connective tissue growth factor as a regulator of scarring. In this, the authors observed that there was significant upregulation of CTGF in the human scarring tenon capsules when compared with the non-scarring tenon tissue by real-time RT-PCR. The CTGF primarily mediates and increases the signaling in the human tenon capsule fibroblast, which is evident because the number of viable tenon capsule fibroblasts were reduced upon the CTGF knockdown. And the knockdown of CTGF basically induces the G0 G1 phase cell cycle arrest. It does not significantly alter the apoptosis. Coming on to role of aqueous. This work was primarily conducted at PGIMER. It is under the process of publication. It was a prospective non-randomized experimental interventional study which was conducted on 92 rats. They were divided into 3 groups. The group A was the baseline, which just got the conjunctival incision followed by a closure with a single tendonylon suture and formed the baseline group. The group B had a silicone tube which was implanted in the subconjunctival space, but it was not connected to the anterior chamber. So basically the group B had surgical trauma with the presence of foreign body. And in group C, as we can see, the tube was connected into the anterior chamber. So there was surgical trauma, foreign body along with the aqueous flow. And that it was seen that the aqueous flow in the tissue acts as a strong driver of TGF-beta expression more than the surgical trauma and the foreign body put together, leading to more inflammation, more vascularization and more scarring at the surgical site. Similarly, the presence of aqueous in the tissue appears to shift the timeline to right by 1 to 2 days, prolonging the duration of proliferation and delaying the remodeling. Coming on to the anti-inflammatory markers, the flow of aqueous led to suppression and delay in the expression of the interferon gamma, as well as downgraded the expression of interleukin 10, which are the anti-inflammatory markers, thereby prolonging the proliferative phase of wound healing and delaying the remodeling phase. So we all know that aqueous has something to do and changes the chemical milieu. But we try to look at the role of fluid, which is name of aqueous and does not contain any mediators. This was an interesting study which was again conducted at the same center along with another center in Australia employing 17 New Zealand rabbits. And in this study, an experimental GDD was implanted in the subconjunctival space without the connection to anterior chamber. And after 28 days, the balanced salt solution was passed through the implant for 30 to 40 minutes at 12 mm mercury, that is the physiological pressure. And we tried to look at the impact of the fluid, which is name of aqueous, on the capsular porosity, which was retested at 3rd and the 6th day. And interestingly, the capsular porosity fell by approximately 80% in both the groups from the baseline even after a single BSS challenge. There was no significant difference in the capsular thickness, but there was significant decline in the capsular porosity compared to the baseline. Now coming on to some clinical high-risk scenarios which predispose the patients to Bleph failure. These are aphakia, pseudophakia, young age, males, black race, neovascular glaucoma, trauma, uveitis, failed trabeculectomy, congenital and juvenile glaucoma, which all predispose to the Bleph failure. This was an interesting article discussing the role of phacoemulsification and studying the cross-sectional morphological changes in the successful filtering Bleph after phaco using Swift Source 3D AIOC2022. And they found that in the control group there was no significant difference either in IOP or AIOC2022 characteristics. But in the phaco group there was significant increase in the mean IOP and significant decrease in the Bleph height, maximum Bleph wall thickness and ratio of hyporeflective space of Bleph wall between pre-phacoemulsification and 1 year post-phacoemulsification. And this was another interesting article which found that the latent infections caused by Chlamydia trachomatis and Bacteroides fragilis were significantly high in the patients who developed Bleph failure compared to the other patients who did not have Bleph failure. So these low-grade infections in the POAG patients may present as a risk factor for post-trabeculectomy Bleph failure. And looking at the other end of the spectrum, the thin cystic Blephs. The application of antimitotics at the time of surgery, which we usually do to reduce the scar formation, leads to early inhibition of healing, thereby predisposing the eyes to wound leak, hypotony and related complications, ultimately causing the Bleph failure. So to conclude, the etiology of Bleph failure is double-edged sword. It is associated also with excess scarring due to complex wound healing after glaucoma surgery, but is also seen due to excessive use of antimitotic agents predisposing to thin cystic leaky Blephs. So a better understanding of this process can help in development of targeted molecules and appropriately time the application of antimetabolites, prolonging the Bleph survival and improving the success rate of GFS. Thank you and have a good day.
So, thank you. I think in this talk we have basically given you the summary of what goes on in the trabeculectomy Bleph and why they fail. It's very important to understand the underlying mechanisms, because when you are taking measure to prevent Bleph failure, or subsequently if you want to revive those Blephs, those timelines are very important, because your intervention has to match with what is going inside the Bleph or in the wound healing area, and if that matches correctly, then you'll get better results. The idea therefore is very important to understand the entire process of wound healing and excessive scarring. So as was mentioned in the lecture, if you have a conjunctival injury or a conjunctival incision, and that heals within 7 days. After 7-10 days, you don't even know where the injury was. It heals so well. But trabeculectomy Blephs, they do not heal. It takes almost up to 3 to 6 months actually. They actually never heal. Even after that, they keep on evolving, so that the tissue never comes back to normal. So the reason is that the underlying mechanisms, they remain active in these Blephs, and that is the reason that we have emphasized so much on this. So the next we'll go to Can you close that? All right. Okay, so the next talk would be, we'll see once the bleph has failed, how we can, it's okay. How we can, what we can do basically to revive those blephs. And you are all aware of the needling procedures and also internal bleph revision. So we'll take up these procedures next. We'll start first with internal bleph revision. I think Dr. Sushmita Kaushik, she's professor of ophthalmology at Advanced Eye Center PGI Chandigarh and has extensive experience in dealing with these cases and also doing internal procedures. So I request Dr. Sushmita to tell us how she does this.
Thank you so much, sir, for the invitation to the course. And I'll be going through AB interno revision. So what is a bleph at risk of failure? If we recognize that, we need to know what to look for. Right, so there are some indicators that point to a risk: excessive conjunctival injection like this, or if there's corkscrewing of vessels. If there's increasing IOP, you should be asking why the pressure is increasing. And typically you could see a high bleph phase, which is insisting of the bleph at about 6 weeks of time, and what they need is aqueous suppressant actually. You could have a flat bleph with inadequate filtration. You need to consider revising, but before anything, always do a gonioscopy and look at your sclerostomy, because no matter what you do, if your sclerostomy is going to be blocked, then doing something in the subtenons or subscleral space is not going to work. So a failed trabeculectomy bleph with high intraocular pressure does have several options. So if you have a scarred bleph like that, you could needle it. You could do a bleph revision, which could be ab externo or interno. Of course, you can do an additional trabeculectomy or a glaucoma drainage device, or maybe a cyclodestructive procedure if there's no useful vision. So how do we decide? A couple of years ago, we actually did a thesis on the clinical utility of the UBM to assess the likelihood of needle success, because what troubled us was not knowing which patient would do all right and which patient wouldn't with the needling. So what we did was we used the UBM at that time to look at the passage of fluid beneath the scleral flap. And the route of aqueous, if we could see it, we call them SRP, or scleral route patent, or a scleral route occluded. And our hypothesis was that the SRO bleph was likely to fail with needling, which was intuitive because the flap itself has stuck down, and if the SRP or bleph was likely to succeed. So sure enough, when we said that, so this is what the SRP bleph looked like, and this is what it looks like 6 months after needling, because all you need to do is do a little bit of subtenons fibrosis release, put in 5-FU, and that's it. Whereas if you have an SRO bleph, which the UBM told us, then no matter what you did to the subtenons fibrosis, that is not going to open up, and 6 months later it remained the same. So we did publish that in Eye a couple of years ago, and we've been using the UBM and now the AIOC2022 to really do something. So now when we realize that an external bleph revision would be required to lyse fibrosis under the scleral flap, it is also true that it's an invasive surgery. It's almost akin to doing a trab all over again, and it does require conjunctival dissection and reopening of the flap. So the whole world is going towards minimally invasive. So this is a sort of minimally invasive revision. It's called ab interno. It's more controlled, and what has helped is the availability of a novel Grover-Feldman biplanar sclerostomy spatula. It's called the GFS spatula. This is what it looks like. The main thing is that it's a long spatula so that you can reach right up to the subconjunctival space through the sclerostomy. It's blunt, and it's about 0.5 millimeters in width, and it's flat, and it also has a bit of a curvature to account for the scleral contour. So these are the principles of the technique. You require an open ostium on gonioscopy. That's the prerequisite. And then you need an inferior corneal paracentesis. You inject viscoelastic to protect the cornea. You insert the GFS spatula under visualization of an indirect gonioscope, and then with side-to-side movement, you can lyse the fibrosis. So, showing a case, this 56-year-old man with primary open-angle glaucoma with failed trab, 24 millimeters of mercury on 4 drugs, and a scarred Bleph and a patent sclerostomy. So, this is a sort of ideal guy to attempt to open up the Bleph from within rather than go externally. So another thing that needs to be given is a subconjunctival mitomycin C, 0.1 milligram per ml. What Grover and Feldman have said in their protocol, it's about a week prior to surgery, but we managed to inject it about 2 or 3 days prior when they come in the preoperative period. So you can see the first thing we've done is inject pilocarpine and constrict the pupil, and then some cohesive viscoelastic on top to put in the lens, and then visualize the sclerostomy intraoperatively as well. So now the spatula is going in, and once the pupil is traversed and you're in the angle, you put in your gonioscope to visualize the entry point. And there is a little bit of corneal folds which do come in, but once the entry point is done, then you gently just do a side-to-side dissection, and this is until you reach the subtenon space. And how you know that is because the spatula is blue, and you'll actually see the blue tip of the spatula, which tells you that you've traversed it. So I'll just show it in a still. Yeah, so here it is. If there is a pointer, if you can see here, this is the mouth, the tip of the spatula which has really come out, and once it is out into the subtenon space, it is easy to keep going side by side and remove all the subtenon. So in one go, you've removed subscleral as well as subtenon's fibrosis and opens up the Bleph. So this is the post-op picture of the same person on the next post-op day. You can see that it's become diffused, there's fluid in the Bleph, and there's nothing much that you've done. On day 7, he was 7 millimeters. This is on day 30, and this is at 6 months, and the Bleph remains much the same. So we're very happy with doing this before going. It's a one step short of doing an external Bleph revision or a retrab or a tube, which is always there. But this is one step before that. If all that can be avoided, it's good. So we looked at our data for this presentation. We looked at people who we had done, and we looked at least 6 months data, and by looking at it, we actually saw that we had patients who had completed 1 year as well. So of course we excluded thin cystic Blephs, a closed sclerostomy site, or a hazy cornea with poor view of the sclerostomy site. So there were 25 eyes, of which 6 months follow-up was in 25 and 1 year follow-up in 15. PACG was 12, POAG was 6, JOAG 5, 1 NVG and 1 secondary open-angle glaucoma. And the mean age of Bleph from trabeculectomy was about 5 years. So there were late failures, and the results were actually quite encouraging. So you can see the IOP has changed, as well as the anti-glaucoma medication requirement has changed significantly. And interestingly, of those who completed 6 months follow-up, only 1 failed, who required another procedure. But those who had completed 1 year, the 15 of them, not one of them failed, and most of them, so in fact 40% had a complete success without medication, and 60% required up to 2 anti-glaucoma medications. So far so good. And our first step now for a failed Bleph is always an ab interno before opening up the conjunctiva and going in. We did have a few complications. 5 patients had hyphema, that's about 23%, which resolved. 1 had to be drained, and there was shallow AC, and one had an iridodialysis, and 1 had a buttonhole. So thank you, and I hope some of you can incorporate this as well. Thank you.
Thank you, Dr. Sushmita. I think it's very important to choose because there are a number of procedures available for these eyes, but which will work for you best or in a given situation. That's very important to choose, and that's what I think one of the procedures Dr. Sushmita has said. We'll go to the next topic. I think we'll do the needling, which is very often done in the conventional sense. Dr. Faisal.
So very good morning. Thank you sir for giving an opportunity. I'll be discussing about Bleph needling. So even with best hand, the 5-year success rate of TRAB is still around 50 to 60%, and the most common cause of failure of the Bleph is subconjunctival fibrosis. In around 10 subtenon encapsulation, that is encystment, can happen in 10 to 20% of the patient after trabeculectomy. What are the treatment options in this scenario? One can reintroduction of or addition of anti-glaucoma medication, which will have again compliance and adherence and financial issues, or a refiltration surgeries which have high high failure rate as compared to primary trabeculectomy. So Bleph needling is a method to dissect the scar tissue adherence between the conjunctiva and the sclera. This reopen the filtration site and restore the flow of aqueous through the pre-existing sclerectomy into the subconjunctival phase, resulting in a lowering of IOP. It can be augmented with 5 adjuvants like 5-fluorouracil and mitomycin C in order to improve the success rate. So pre-operatively, this madam already showed that the gonioscopy and the ostium should be patent. So this is a patient who had TRAB around 8 years back. I am showing the 2 videos. So first, in this topical anesthesia, you can inject BSS into the subtenon spaces. Then spread these BSS around the Bleph and towards the center, because most often this fibrosis should be just above the scleral flap, more fibrosis in the scleral flap area. So spread it out, try to spread towards the center and towards the limbus. So once you spread out, the remaining part should be tackled with a 26 gauge bent needle. Pass through the subtenon spaces. Then start dissecting in a horizontal direction, that is dissect the subtenon fibrosis in sideways. Most of you now need to enter into the AC. Complete the dissection. During the procedure, now you can see the Bleph is lifting up. That's for me, that's for recannulation of the Bleph. So then check the then now you have to go of the make a paracentesis incision, and followed by making AC reformation. If required, then hydrate the side port. At the end of procedure, you can give 5-fluorouracil. It should be at different levels. It should be more superficial and more periphery of the Bleph. If required, make a paracentesis incision and reform the anterior chamber. So this is the same procedure, just another video. I'm just showing the. So after this, during the procedure itself, just go the needles and sideways. So just go and sideways. Then during the procedure itself, the blood trickling happened into the anterior chamber. That means just dissecting the fibrous tissue. The sclerostom is already patent, so that's the blood trickled into the anterior chamber. You could see the blood. So what the literature said? Literature said the success rate of trabecular needling with an MMC around 60 to 70%, whereas the success rate augmented with the 5FU is slightly lesser, that is 30 to 65%. And another report from Singapore National Eye Institute, they had a success rate of around 60% over a period of 2 years. This article, they compare an office procedure and an OR procedure. Some surgeons do a clinic procedure. They found that both are equally good to rescue the failed Bleph. There is another study that's from Dr. Vanida and her groups. They found that they rescued a TRAB around a success rate of 84.6% at the follow-up of 20 months. That is more than 18-month follow-up. There is another study that done in children. They rescued the treb around 77.7% of the cases at around 19 months follow-up. So they've concluded that this is effective. The short-term and intermediate outcome in children is also promising. So complications are subconscious hemorrhage, most common, hyphema, punctate epitheliopathy due to maybe due to toxicity or accidental installation of 5FU over the cornea, choroidal detachment, and cataract formation, and hypertony. So blood needling is an inexpensive, simple intervention with less surgical trauma that can have a moderate outcome for rescuing failed treb or failing trabeculectomy. It can do as a slit-lamp procedure in your office itself. Thank you.
Thank you, Dr. Fajal. Yeah, I think it's very important again to highlight that there are a number of procedures, but what you want to do actually depends on the case at hand, and that we have to understand the mechanism why the Bleph has failed in the first place. Next, I'll do a limited posterior Bleph revision, another procedure.
Hello. Can I ask a question for the
previous? Yeah, sure.
About the ab interno, the spatula, is it available here? The spatula that you showed?
Yes, it's available from Epsilon and costs about 3,000 rupees.
What is it called? Just
Grover Feldman. It's by Devinder Grover.
Okay.
And Grover and Robert Feldman made it. So it's called the Grover Feldman spatula, and Epsilon must be selling it here.
Thank you so much.
Yeah, so in their protocol it was 1 week prior to the procedure, 0.01 milligram. But the logistics don't allow that, so whenever the patient comes preoperatively about 3 days prior, we inject it in that area, but you have to then massage it and spread it over. So it stays in place, and you operate within 3 or 4 days after.
We will have some time, I think. We will have some time, for question answer. So, okay, just to keep the time, I think I'll take you through another procedure, limited procedure revision of the Bleph. The Bleph failure, as we have already told you, this is very common, and there are a number of procedures available. Many things have tried in the past, actually, with the mixed kind of a success rate, and we have heard about the needling and the internal revision as well. But sometime, if there's no fluid pocket and the skull flap which are dissected is really stuck, to its bed, and there's a fibrosis there, the needling, external needling actually doesn't work, and the internal procedure becomes very difficult to execute because there's a lot of fibrosis. So in that situation, you might have to open that area and do the surgery. So something like this, when you have a case where there's a lot of scarring is there, and as you can see, the eye has been operated, but the flap is completely closed, and there's no fluid pocket under the flap or above the flap. Now in this situation, one could do another procedure which I call a Bleph revision through external keyhole incision, or BREKI, brachy in short. So this is a relatively newer procedure, not much used. But what you do is that you make a small keyhole incision in the conjunctiva away from the Bleph, and advantage is that you are making smaller incision, you are dissecting less, so it leads to less tissue trauma and hopefully less fibrosis. So it could be done under peripheral anesthesia or even subtenon's infiltration. Globe would be rotated downwards, and you need a side port to keep access to the anterior chamber AC. And I'll show you in the video next how first the diagrammatic representation basics. So this is how this you make an incision behind a little posterior to the existing Bleph. Important thing is that on table should be identify where the Bleph area is. Then go identify the sclera and go subtenons in the episcleral plane, and you just dissect bluntly mostly towards the towards the Bleph area until you identify the skull flap. And once you identify the skull flap, you push your scissors by blunt dissection, small scissor, under the flap. And once you reach that plane, then you can put mitomycin C and as you do for other other trabeculectomies, and give a thorough wash, and then you can carry forward the dissection. And when you have reached under the flap, really just by the opening of the action of your scissors, you'll encounter the fluid will start flowing into the area, because once the flap is lifted up, the trabeculectomy site is already patent, and the fluid will come through, and then you'll get a nice Bleph in that area. So I'll show you the video. Can you play the video, please? Yeah. Can you play the video from there? Some of my videos are not playing. Okay, I'll choose from here. I can see it. All right, I know which one. All right, so this is how you do the procedure basically. So you can see there's a Bleph, which is a scarred Bleph there. So you go posterior to the Bleph about 7-8 millimeters, and go cut conjunctiva as well as the Tennant's capsule. Identify the sclera. So go deeper, and now you are actually going in the episcleral plane, or in the subtenon space. Because subtenon is difficult to identify because there's a lot of fibrosis there, but with a little dissection. Now we are doing a blunt dissection mostly by the opening action of the scissors, and you mobilize the tissue around that incision site. So now use bigger scissor and so that you can create a larger pocket on either side and also posteriorly. So once you have created that pocket there, through that small incision, so this is just to show you the distance, basically about 7 millimeters in this case. Then use mitomycin C. So use 2 or 3 sponges like you do for any routine trabeculectomy. I routinely use 0.2 mg/cent for 2 minutes, and once the time is there, it's better to have access to the anterior chamber through a side port incision, because subsequently if you need to reform AC or stabilize AC, you could inject into that. So after you have removed the sponges, give a thorough wash and continue with the dissection. Now I am actually identified the area of that the previous Bleph, and I'm going under that. So just follow the sclera and make sure you go under the flap. So that's the only tricky step here that you have to identify. And once you have gone under, keep dissecting, and at some point the fluid will start coming out. Now you could see the fluid is coming out, and you can check it by injecting fluid in the AC, and you could see when you inject fluid in the AC, it comes out, and that is actually the end of the surgery. So now you just close this this wound with whatever suture you use for closing conjunctiva. I am using 8-0 Vicryl here. So just put a few, because just a 3 millimeter, 4 millimeter incision, so it closes very quickly. And in the end, you can again recheck the patency and reform the anterior chamber. So you see the dissection is minimum, and you have achieved a very nice communication between the anterior chamber and the subtenon space. So I'll go back to the presentation. All right. Okay. So this is how basically your Blephs look like in the early post-operative period, and this is a little later. You can see the scar here. That the scar is a small incision which has healed, and you have a nice Bleph anterior to this, as also on the sides. And similarly, another patient you can see here in the early post-operative period, the wound is healing here, and post-operatively you have a nice formed AC, which is the eye is very quiet. And this is another, again you can see the wound is healing there, and you have a nice fluid around the Bleph area. So The prerequisite, of course, is the surgical site should be identifiable and make sure that your fistula is patent gonioscopically. And we do look for any fluid pocket under the conjunctiva, under the flap. And if that is present, then we do needling or ab interno or externo. But if it's totally stuck, then we'll do this procedure. The contraindication, of course, will be if you can't identify the previous the site, if there's staphyloма or there's extensive scarring, thick pace, and if it's blocked iridectomies or irises blocking the fistulas, those situations we won't do it. So just a quick experience, I looked at the last 44 eyes that we have done with this procedure, and you can say we have done it for all variety of reasons, indications, and the IOP control is fairly well. You can see that even up to 3 years, we have a follow-up to 3 years in these patients actually, and you can see the IOP is very well controlled. Most of them is maintained under 15 millimeters of mercury with or without drugs. So some of these patients do need the post-operative drugs. So this is not a unqualified success rate, but a good success rate actually to control IOP. And if you look at the cumulative success rate, almost 70% at 3 years, over a period of 3 years, so which is pretty good for given that these eyes are actually at higher risk. So to conclude, Bleph revision through a keyhole incision is a viable option and should be considered when your needling ab interno or ab externo is unlikely to succeed. Thank you very much. I think next we'll go to the next topic. If you have any quick questions, we can take it here. Otherwise, we can take them towards the end. Yes, please, there is a question.
What exactly is the timing when you take up this thing?
These are usually Blephs which have been there functioning previously, and the eyes are quiet. So you will avoid doing it in an eye which is still inflamed or active, because then it will bleed, there will be blood clot there, and that will lead to more fibrosis. So you want to do these in eyes where the Bleph is scarred down, and the other methods have basically failed.
How would you treat them post your revision?
Sorry,
Your post revision.
Yeah, it's just like you do for a trabeculectomy, much less aggressive actually. And the important thing is that you can supplement post-operative with a 5-fluorouracil if you need to, because you have already used MMC on table, but if you feel there's a more vasculitis coming up, you can use supplement. But basically you have to maintain the IOP and keep massaging this Bleph so that the adhesions which are forming, you keep breaking them in the first 2 or 3 weeks. So it does need post-operative care like you do other trabeculectomy, but much less aggressive, I would say.
Is there any chance of MMC getting inside the AC? If it is somewhat taken?
No, we are not injecting, and we are applying AC before actually we establish the flow. So we do it. So that's why I dissect first, identify the flap, go under it. Once you are sure that okay, now you are able to go under it, then don't complete the procedure. Do mitomycin C, and then come back to complete the procedure.
Thank you.
Well, if you don't have access to, then you have to go by your clinical judgment only. Yeah. Yeah.
If you don't have the UBM, one clinical pearl is to look at the sclerostomy, and usually if it's fish mouthing, you can be sure that there's some fluid percolating in, which we found in the SRP Blephs. But in the SRO, the occluded ones, the sclerostomy is usually a slit. If you have a slit sclerostomy, probably there's no fluid.
So this procedure for SRO Blephs and needling ab interno or externo is for SRP Blephs. Okay, we'll go to the next, Dr. Sriras, please.
Good morning. So I'll be presenting total revision of the Bleph failure, that is flat Bleph with high OP. That is the alternative to the limited Bleph, which Dr. Pandav has already discussed.
Do we have the keynote address also?
So this is type of Bleph which we aspire after the trabeculectomy. But that there are lots of post-trap complications. So we will be discussing raised IOP with deep AC, which can be due to the blockage of internal ostium or the external. So these are some of the risk factors for failing of the Bleph: young age, GOAGR, PCG, subconjunctival hemorrhage, or excessive inflammation. So failure can be due to ab externo causes, tenons, capsular, encapsulated Bleph, or flat fibrous Bleph, or ab interno due to closure of the ostium. So recognizing the characteristics of a failing Bleph is very important. So there is gradual rise in intraocular pressure with deepening of the AC, change in Bleph appearance, that may be a pulsant or flat or a very elevated smooth dome shape, or can be surrounding fibrotic vascular ring and loss of microcysts. Intraocular pressure may not decrease even after Bleph massage. So we have to identify the cause. First and foremost is the meticulous slit lamp examination. We may find sister Bleph or a flat Bleph, and this is crucial for deciding strategy for revision. Gonioscopic examination is very important to rule out the closure of the internal ostium. UBM, as Dr. Susmita discussed, helps in determining the internal characteristics of Bleph such as fluid reflectivity, Bleph wall, but disadvantage is the low resolution. Anterior segment OCT can also aid in deciding what strategies to be used. It is a better Bleph imaging modality. No coupling median is required, no spine position is needed, and it is contact lens and gives us high resolution. And it characterizes Bleph in terms of suprascleral fluid measurements, Bleph wall, scleral flap, aqueous humor pathway, and iridectomy opening. And cystic Bleph usually hyporefractive with multiloculated fluid collection, and capsulated Bleph is thick Bleph with high reflectivity and enclosed fluid filled spaces covered by thin layer of conjunctiva. And flat Blephs are usually gives high scleral reflectivity with no Bleph elevation. And these are the pictures of a overfiltering Bleph. The upper one is with multiple fluid pockets and shallow AC, and inferior is the AIOC2022 after putting the compression sutures. We can see the limitation of the Bleph and deepening of the AC. So AIOC2022 really can help in deciding which strategy is to be applied. So management developed on diagnosing, then managing the intraocular pressure conservative, then restoring the Bleph function, and salvaging the failing Bleph or Bleph revision for a frayed Bleph. So these are the mechanisms for salvaging a failing Bleph, and if the Bleph has already frayed, then you need Bleph revision, and there are various strategies. And I will be discussing revision of failed trabeculectomy, that is complete revision from the same site. So complete external revision from the same site is more invasive surgery. It requires conjunctival dissection to the sufficient horizontal extent, at least 8 to 10 millimeter posterior to the limbus, and reopening of the same sclerotomy flap and also augmenting it with the antimetabolites. So methodology is corneal stage sutures, delineate the scarred area by moving the conjunctiva over the Bleph. Posterior fornix based conjunctival incision is given at least 8 to 10 millimeter from the limbus, and it should be of sufficient horizontal length to expose the whole of the Bleph area. Thorough dissection till sclera is done with fibrous tissue, episcleral fibrous and scleral fibrous tissue is removed across the surrounding the Bleph, and then a limited part of the posterior part of the Bleph, that is posterior half of the sclerostomy site is opened up. We can enter the blade with 15 degree or MVR and till the aqueous outflow is observed. So we can fill the anterior chamber with high molecular weight viscoelastic through the same opening or through the side port, so as to create a positive pressure inside, and after that we can apply MMC, and the wisp should come till the apex of the sclerostomy side, and positive pressure in anterior chamber due to viscoelastic prevents its entry into the anterior chamber. This is the limited Bleph dissection, as Dr. Pandav has already highlighted, and incision is similar in total Bleph revision also. Only thing is it is of a larger horizontal extent. Advantages of same site revisions are that optimal position of Bleph opening is there, and we are using the same PI site, and we are leaving the healthy surrounding conjunctiva preserved for any future surgery. Because most of these surgeries fail at some time, so need to keep it healthy conjunctiva for future surgeries or GDD. So this is study by Coot et al. Same site posterior Bleph revision of failed trap. Here they had opened only a part of the, that is posterior half of the scleral site, and their result shows that even after 5 years without treatment, they were able to maintain pressure less than 15, though the number of patients at 5 years were less, and anti-glaucoma medications also decreased. Another study by Nikita et al. Also shows the similar results, and as I was going through the literature, I found that most of the studies on opening through the same site gives us the similar level of pressure lowering as in a fresh trabeculectomy. This is another study. So in conclusion, literature do support the reasonable success with Bleph revision, that is complete Bleph revision from the same site, and it preserves the healthy surrounding conjunctiva for future glaucoma surgeries. Anti-metabolites may be needed a little higher concentration because of the massive fibrosis, and complications are less because we are opening only limited part of the sclerostomy, and peripheral iridectomy is not needed, and it is an excellent alternative to repeat trabeculectomy or tube shunt because it gives almost similar result as the new trabeculectomy at a new place. Thank you.
Thank you, Dr. Shrishti. I think your nice overview. I think your video got truncated, but we will go to the next talk. I think whatever surgery you do, doing a good job on table is very important, of course, but equally important is how to manage your cases post-operatively, and something goes wrong, then how to deal with that. Dr. Sonam is going to take us through. Dr. Sonam is assistant professor at Advanced Eye Center, PGH Chandigarh. She will tell us how do we take care of after the trabeculectomy routine, as well as, especially when you've done a repeat procedure, whether this is a limited or a complete external revision. Dr. Sonam, please.
Thank you, sir, for giving me this opportunity. So I'm going to discuss the post-resurrection Bleph care. So at the end of the day, after any filtration surgery, our aim is to have a diffuse and functioning Bleph. There are some predictive factors for Bleph revision. First and foremost is your pre-needling intraocular pressure. Any patient who has a very high intraocular pressure, that is considered to be an independent risk factor for failure. And a lack of MMC is also known to correlate with the success of revision. That is, in patients where mitomycin C was not used, then the failure was higher compared to that in which the mitomycin C was used in the primary trabeculectomy. Also, the intraocular pressure in the immediate post-op following in needling or revision is considered to be a good prognostic factor. It is correlated in the fact that the surgeon is able to dissect out the fibrotic tissue to that an extent that the intraocular pressure has come down. So this is considered to be a good prognostic sign. Other than that, multiple needling procedures and patients who are on chronic medications who are more prone to fail, that is again a poor prognostic factor for revision as well. So coming to the morphology of the Bleph, that will give us few clues whether the surgery is going to succeed or not. Bleph vascularization, microcystic changes, and timing of needling, they are considered to be good prognostic signs only in elevated Blephs, but not in all cases. So this is again correlated by the fact that having these characteristics of vascularization and some microcystic changes, it shows that the remodeling phase of the primary trabeculectomy is still going on, and there is a scope of further resurrecting or improving the outcomes. Other cases like non-injected or ischemic Blephs carry a poorer prognosis. Bleph height in some studies show that there is a good prognosis if the Bleph height is good, but only if you do an early needling, those elevated blephs fare better. While in a flatter or a smaller bleph, higher failure risk is again seen with revisions. As I already told, at the timing of needling, early needling is known to carry a better prognosis in elevated blephs, but no correlation per se in a flat bleph. Peroperatively, few surgical pearls that one can keep in mind is to lower the intraocular pressure, since a high preoperative intraocular pressure carries a poorer prognosis. So we must bring down the pressures to a lower side and then perform the surgery. And you must you can consider either a topical or a periorbital anesthesia depending on the surgeon's comfort as well as the patient's comfort and the patient's cooperation. And we should never use any sharp or tooth forceps while handling the conjunctiva, because you may end up with inadvertent injuring the conjunctival tissue. And also always aim for a watertight conjunctival suture and never leave the OR with an unclosed leak. In the immediate postoperative period, again, as I already discussed, intraocular pressure less than 10 mmHg is a sign of preliminary success. You should always monitor the anterior chamber depth, because in the presence of a low IOP, you can have a shallow AC like a choroidal detachment or so. As in any trap procedure or any glaucoma surgery, you should control the inflammation with the help of steroids, cycloplegics, and antibiotics. And around 1 week till up to 1 week of the surgery, inflammation and fibrocystic migration and proliferation is still going on. We must keep on monitoring the intraocular pressure and look at the appearance of the bleph, and always, as Sir has described, keep on giving massage at every visit to form a diffuse bleph. And you may consider at 1 week again giving a 5-FU injection. At around 2 weeks, fibrous proliferation and vascularization process is ongoing. So again, monitoring the bleph and looking at the vascularization. You should keep on continuing the steroids in this case and massage as and when needed, along with 5-FU supplements. At up to 4 weeks, the remodeling process is going on. So you should always look for any localization of the bleph and keep the bleph always diffuse. And again, keep depending on the morphology and the other inflammatory signs, you should think of giving an injection of 5-FU. At around 6 weeks, the vascularization is going to reduce, and then you see a diffuse bleph. That is well and good. And at that point of time, you can think of tapering off the steroids and stopping it. But in some cases, the localization process, the remodeling process is giving rise to an incisment or localization. Then you should think about using, consider using an anti-glaucoma medication and continue with bleph massage. At around 12 weeks, if the bleph is encysted, you may plan another needling procedure or revision. But if it's a flat bleph, you can plan a repeat surgery or a glaucoma drainage implant in such cases. And always remember that doing any filtration surgery and a revision surgery is constant. It's a constantly more evolutionary. It's the bleph is always undergoing changes throughout. So it's an ongoing process. So you must keep follow up over a period of many years. I'll just touch upon the few complications of bleph needling and revision. Unlike a trap procedure, hypotony or chronic hypotony is not very commonly encountered. But yes, we do see hyphema, shallow AC, bleph leaks, choroidal effusions, and rarely suprachoroidal hemorrhages and endophthalmitis. So when you look at a shallow AC, when you see a shallow AC, then you must think about the common causes. That is leak, most commonly conjunctival suture, conjunctival wound leak, or a choroidal detachment. So if there's an early bleph leak, think about looking at the cause. If there's a proper Seedles positive, then you can either consider using a large diameter bandage contact lens or a resuturing. So again, at the time of leakage, if you see an early bleph leak, do not jump onto decreasing the steroids, because the steroids are essential in actually halting the fibrosis process. So you should always follow the patient up closely. And as I already mentioned, a bandage contact lens or a direct suturing can be done in such cases. Suprachoroidal hemorrhage is a very rare complication, but we can always prevent it by bringing down the preoperative intraocular pressure low with the help of hyperosmotic agents, and a scleral flap if it's open, then we should close it immediately along with anti-glaucoma medications. Choroidal effusions mainly get resolved with the help of topical steroids, cycloplegics, and systemic steroids. And endophthalmitis is the most dreaded complication for any ophthalmologist, especially blebitis and Bleph-related inflammation and endophthalmitis can present at any point of time after trap surgery or glaucoma surgery. We can prevent it with the help of, by prepping the eye with antibiotic topical drops preoperatively. Installation of betadine is essential, and again, post-operative antibiotics. We should always explain the patient the RSVP sign as described by Professor Parish. That is redness, sensitivity, decrease in vision and pain. So we should tell the patient at any point of time in follow-up, patient should always keep these 4 points. I would like to conclude by saying that maintaining intraocular pressure low with medical management until the needling procedure has a positive effect on success. In case of a secondary glaucoma, patients who are on chronic medications, there's a risk of fibrosis with every surgical intervention, and a better case selection, taking into account the morphology of the Bleph and the timing, since primary trabeculectomy may improve the overall outcome after revision. Thank you so much.
Thank you, Dr. Sonam, for excellent presentation. Do we have Dr. Noor Samshia in the hall? Dr. Noor Samshia, there is a keynote address by Dr. Noor Samshia on neovascular glaucoma. If he's not here, I think we can take up the questions then. Are there any questions from the audience? So, Dr. Shishmita, when you do the interno procedure, how hard it is actually to negotiate? Because sometimes I find, if you put the cannula even through the ostium, it doesn't actually. It needs to be negotiated hard at times because it won't lift the flap up.
Yes, sir. Thank you. It does get a bit tricky initially, but usually if we have managed to get into the sclerostomy, then it's reasonably all right. And one trick that I've learned over time is not to immediately start doing a side-by-side thing, but go straight in, because that's the triangular flap we usually make, and go straight in, and once we are in the subtenon space, then it's easier to lyse it the other way around. So sometimes it does, but once we I find the trickiest part is negotiating the ostium initially.
I think for a beginner, probably that takes a little while because you're looking at the through an inverted image.
So when you're actually thinking that it's up, it's actually down, and the other way around. Yeah. So we did try the direct. We thought that would be easier to just put it in. The problem with that is all direct lenses require the microscope to be tilted and the eye to be tilted too. So since the trabs are superiorly, if you tilt the eye, it goes into the fornix, then you can't see it. It's not the same as doing a goniotomy where you're doing it in the horizontal, then there's no problem. But vertically, there is no tilt, which is why you need an indirect ophthalmoscope, because then the lens is superiorly and you're seeing, the lens is inferiorly and you're seeing the superior and it's end on. That's the only problem.
I think pushing it through is, I think once you have found the ostium, pushing it through is okay, but I think I find it hard to go the side-to-side movements because your cannula is stuck at 2 points. One is your incision and one is the ostium. So they are the two fixed points basically, and negotiating beyond that becomes a little.
Through,
yes,
and it's in the
to and fro you can do it, but the side-to-side is very
difficult
to do.
This, and then it comes out.
And you use mitomycin before surgery, pre-operative.
Yes,
So is there any difference in using these two, like if you on table or?
So I think the problem with on table would be that there is no way to wash out. All of it will go into the eye. I think that's why they must have made a protocol of a couple of some days prior. Unlike an MMC on table for a trabeculectomy, because there in any case you're opening up your conjunctiva and then everything would be out. But here if it's on table, it's a bolus and then it's all closed and all that MMC is into the anterior chamber. I think that would have been the concern. So I've never used an MMC on table. I've always used it prior.
How many days before you use? 7 days?
They've said 7 days, but logistically it comes to about 3 days prior when we do our pre-ops and then.
And any questions regarding this one? Yeah, Dr. Shirisha?
Yeah, so why can't we give it in a different location? So MMC on table, but rather than giving it exactly the area of your ostium and the Bleph, because we do it on table and we give it in a location which, let's say, if supero-temporally is where I start my needle. I mean, this is not the exact technique that you're talking about, but even there, I guess, supero-nasally we give the MMC injection. So that but it is not in the same plane. As long as you are delineating the planes and it doesn't go into the anterior chamber, it should be okay.
I mean, how would you know that your MMC is not in the same plane?
Because it is in a completely different, so it is superiorly, but it is in a completely different area, because
position.
you know until where your Bleph is elevated, right? We do it after the needling. Okay. You know until where your Bleph is elevated, so you go beyond that. So we've never had a problem, at least as far as until now, because this is a routine that's followed for several years. So again, like you said, if you have the opportunity of seeing the patient 3 days before and then taking it up, it's okay, but majority of the time they wouldn't. So you do it on the same day in a minor OR, you might as well give an injection in a different location. Of course, not inferiorly like the way you do 5FU, but it is in the same quadrant, but in a different
after the procedure,
location. Yes.
I think I do that for 5-fluorouracil because I use 5-fluorouracil more often after the needling procedure, than mitomycin C. And there we do it, after you have had that Bleph, because the Bleph is actually subtenons and the 5F you are using is subconjunctival. So there's a bit of a separation in the two. And also you are shifting it a little more either to the nasal side or the temporal side, so you're not directly in that area. And I think, like Dr. Shirisha is saying, it works well. So we haven't had any problems with that. 5FU we
always use at the same time, needling, even when we do it at the slit lamp. So you do a needling and then a 5FU.
You could do that.
Somehow,
but even 5-fluorouracil, if it goes into the AC, then there is a problem. So that concern remains there for both the drugs. Yeah, that's true for both the drugs. Any other issues? I think after this limited, Bleph revisions, whether it's a needling, ab interno or externo, or a limited dissection, important thing is that you can actually make these traps function again. And if trap which has functioned for some, my indicator is that if there's a trap which has functioned for a few years and has failed, that actually has a very good chance of revival by one of these procedures. Now, if your trap has failed very early and there's a lot of fibrosis or there's active fibrosis there's a fibrovascular proliferation still active, those I will not do well with either of these procedures. So I prefer to wait till the eye becomes a little quieter and the vascularization has receded, control pressure with drugs, systemic if required, and let the eye become quieter and then choose one of these procedures. And as we have tried to explain, the way we choose it, that if you have a Bleph, there is a small encysted Bleph, that needling will be a better option there. But if you have the flap which is kind of which has sat on its bed, but there's not much of a fibrosis around, I think internal revision would be internal needling would be a good procedure there. But if you have a flap which is stuck to the base and there's some amount of fibrosis as well, I think there you could do the external revision or through a keyhole incision. That would avoid a larger dissection, and you can use the whatever has already been done. The fistula is already made, the iridectomy is already done, flap is already there. So you are using what was done in the previous surgery. You are using that, and you can do a little bit dissection and get away with it. So that's the idea behind this Bleph revision through a keyhole incision. That's Shirisha.
Yeah, one point I would like to add, what has helped me is that once we do the needling revision, not the revision, the needling, the point of entry of the 26 gauge needle, I always close with a 10-0 nylon suture. The reason why I do that is, although it is in a multiple plane, and not that I'm worried about too much of a leak on table, but from day one post-op onwards, I ask them to massage. So digital massage by the patient themselves goes a long way. And how long, when you ask me, usually we see them on day one and then 1 week and 1 month based on the logistics and how far they stay. So I asked them to continue doing the massage. By about a month, generally it settles down. And if it is filtering until then, that means your Bleph is going to function in the long term. So that massage, I believe, is very, very helpful. And for that, when you do, I've seen a couple of patients where without the suturing of that tiny little opening, they can leak when you do a massage. So on table, I generally put one single 10-0 nylon suture and then advise digital massage by the patient.
Even with the 26,
26
gene,
yes.
yeah. So I think we should do that, because it's true that these eyes, the Bleph the space need to be maintained, because there's a tendency for adhesions, and I think I agree with Dr. Sirisha. Bleph massage is actually very important. We do it every time the patient comes to us, but we don't recommend at home from the patients. Maybe we can try that as well. And it's not only during first 4 or 6 weeks. I massage these Blephs even after 1 year or 2 years after surgery, because many times you see there's a good Bleph and the pressure is 12-13 millimeters of mercury, and suddenly patient comes and the pressure is 16 millimeters of mercury and nothing seems to be changing. You massage these Blephs, and I think you should be able to break those adhesions. That becomes more diffuse and the pressure comes down. So I have seen that, as I said earlier also, these Blephs are not static Blephs, they keep on evolving, and over a period of time the Bleph won't remain the same. It will, sometimes they go toward the thin cystic side, and sometimes they'll go towards becoming a little flatter and more localized ones. So the Blephs which are going towards localization, I think the Bleph massage really helps you there. But if they're getting thin and cystic, then you have to wait and watch, and your approach has to be different. So trabecular Blephs, post-operatively, it's not 2 weeks, 3 weeks, or 4 weeks. It's a kind of ever going process, and we have to keep that in mind. Any comments? All right. So if there's no more questions, I think
can I ask?
Yes, please.
So can you please elaborate a good technique for a Bleph massage that can be done by the doctor, and will it differ from the kind of Bleph massage that we advise to be done by the patients at home?
I think Bleph massages actually depends on the purpose for what you are doing. So in the early post-operative period, when they are, these days you suture flaps a bit tight so that the AC is maintained and there's no shallow AC. And the post-operative period, if there's no Bleph, then the role of the massage would be to create the Bleph. So in that situation, I prefer using a Bleph above massage above the surgical site. Just depress the sclera a little bit to create a tangential force and fish mouthing of the flap that you have created, and that forms the Bleph. So that's the one way of doing it. But the purpose is different.
Do you use any instrument for the same purpose?
You could use, normally there's no need to use an instrument, but if it's not coming, then you can use what we call McPherson's forceps, just to depress the sclera beyond the margin of the incision. So idea is to create a fish mouth there, so that the aqueous comes out, and once it starts coming, it keeps coming. So that's the one way, and one purpose for the Bleph. The other is that your Bleph is now there, but is getting localized, and there you have to press directly over the Bleph area. So where you have a little Bleph blister there, you just press on the blister, gently pull down through the lid, and try to make it diffuse. And you can actually see the Bleph. If you're doing it on slit lamp, you can see the the fluid dissecting the subtenons or subconjunctival space, usually subtenon space. So you can see the fluid going through like a hydro dissection. So you can actually see that happening. So you keep doing that to keep the Blephs diffuse. I usually don't recommend home, but the home massage would be probably of the second kind, that you through the lid, you could do that. I think some people also
center of the cornea through the lid.
Some people also do from the inferior lid and to push the aqueous through the ostium. But I usually prefer from the superior lid only. Dr. Sirisha?
Yeah. Yes, please.
If I can just add, so while we do it, like if you are doing the massage for the patient for exactly the same reasons which Dr. Pandav said, some of us use tight sutures, some of us use releasable sutures, and then when we want to see which of the sutures is tight, or do we need to release it, or it is just sometimes subscleral heme, which is kind of fibrin, which is kind of sticking the two flaps, with a little bit of massage, the fluid now will start flowing. You don't have to remove the suture. That we do under the slit lamp with the pressure over of your thumb or your index finger. Under microscope, under the slit lamp visualization, 2 things you do. So you put your finger over the lid and then you give a massage in the area of the bleph. That helps not just to give massage for the fluid to drain, it also shows you how much of force you require, that is you will realize. Number 2 is how big is the bleph forming. Without realizing, if you do it, too much of fluid will go out and you may even have a flat anterior chamber. You need to be very, very careful when doing that. When we ask the patient to do the massage, we never tell them within the first 3 weeks when the conjunctival edge has to heal. So unless it is a limbal-based trap where your incision is right posterior and you're not worried about bleph leak and things like that, we generally tell them 2 or 3 weeks later, depending on, so if it is a tighter suture and you know with a minimal massage the bleph is forming very well, or a little bit more indentation is required, then we teach the patient to do it from the inferior part. So we teach them, we said this is an exercise that you need to do the bleph, and they are quite religious. But we explain it to them and we usually ask them to use it. Look up, because cornea should not be in contact at all. Look up and over the inferior sclera we ask them to give a massage. I ask them to count 5. So give a constant pressure and ask 1, 2, 3, 4, 5 and then release it. Then 1 more time, then 1 more time. So 5 times and 5 count each time. And that seems to be helpful and over the day. Yeah. Because you also realize when you do that massage and when you see the bleph is elevated, you make the patient wait and then call them back 2 hours later and see again the pressures will be 30. So this is like in the early post-operative period when you know removing a, let's say there is 1 suture and you don't want to remove it, or removing the sutures too early. If it is risky, high myopes and things like that, then I would actually wait with a bleph massage for a short while before I remove that suture for a permanent decrease in IFP.
Thank you, Dr. Any other questions? Can you use the mic, please?
I have heard that for early conjunctival leaks, when we use tobramycin eye drops 3 or 4 times a day for a period of 1 week or so, I have also seen in my cases that the leaks have stopped. So is there any such similar experience or advice on the same?
I think the small leaks, they will always stop, given an adequate chance. The only issue is that by the time your leak stops, the rest of the conjunctiva may get fibrosed. So any fistula that the eye will try to heal, but by the time the rest of the trab would have failed. So that's why it's very important to address them early. So if you have a micro leak at the limbus in a phonics-based trabeculectomy, many times you would use a large size contact lens that gives you a little pressure there. But if that is not working for 2-3 days, 4 days, we don't wait for more than 2-3 days actually. And if it's not working, consider working in the sense if there's no improvement in the AC or in the bleph, I think consider doing a resuturing in that area.
Thank you, sir.
Okay, thank you very much. I think the neovascular glaucoma lecture is not there. Thank you all very much for staying with us, and I hope we have been able to, discuss some important points. Thank you all the faculty, and thank you AIOS for giving us this opportunity, and all the audience. Thank you for coming and staying with us. Thank you all. We are finishing, I think, 10 minutes in advance, 13 minutes in advance. Thank you.